Good evening, everyone. I'm Michelle Leifer, and I'm the director of the USAN Institute for Animal Health Education at the Schwarzman Animal Medical Center. Along with my colleague, Kimberly Young, I'd like to thank you for joining us for tonight's event, Seizures and Epilepsy in Dogs and Cats with Dr. Daniel Cimino. This webinar is for informational and educational purposes only and is not intended to substitute for professional veterinary medical advice, diagnosis, or treatment. If you have questions or concerns about your pet's health, it's always best to consult your veterinarian. Tonight's event will be recorded and we'll send out a link tomorrow in case you miss anything or would like to share with a friend. We will be taking questions via chat and we'll save some time at the end of the presentation to answer as many as possible. I'd like to take a quick moment to let everyone know about our next event on Thursday, February 27th at 6 p.m. We will host Feline Dental Health with Dr. Ada Toe. You can find more information and register for that event on our website, amcny.org/events. We'll also have that link in our newsletter that goes out tomorrow evening. And now it's my pleasure to introduce tonight's speaker. Dr. Daniel Cimino is a board-certified neurologist and a senior veterinarian in AMC's neurology service. He grew up in New Paltz, New York, the youngest of 5 children. He played football and obtained his undergraduate degree at Ithaca College in 2013, after which he spent a year working in 2 of his hometown veterinary hospitals, gaining additional experience in small and large animal practice. He then went on to earn his veterinary degree from Cornell University, after which he completed a 1-year general internship at the Animal Medical Center in 2019. He then stayed at AMC to do a residency in neurology and neurosurgery before joining AMC's very busy neurology service as a senior veterinarian. We're very grateful to have him here with us to lead tonight's event. He's back for his second USAN webinar. The first one was just over 3 years ago, and on IVDD, that's on YouTube if anyone is interested. It's an excellent presentation, but we're very excited for this one as well. So please join me in welcoming Dr. Daniel Cimino.
Hi, thanks very much. Thanks everyone for coming. So let me just share my screen here. Okay, share, and we make it big. Is that working? That looks okay?
Good,
Okay,
great.
fantastic. So I'm Dan. I'm one of the neurologists here, going to be talking about seizures and epilepsy in dogs and cats tonight. And I'll start off with, this is a huge, huge topic. So this is meant to be an overview. I'm touching on what I think are the most important points, but just know this is not exhaustive by any means. But hopefully I can answer a lot of your questions regarding this with this presentation. So some fun facts about seizures. Earliest reports, they've been around forever. So earliest reports from Mesopotamia in 2000 BC. This second one I thought was really astounding, in that in humans, 1 in 10 humans will have a seizure. Now, that's not the same as them having epilepsy. They're not going to have seizure disorders. But at some point in life, if you were in a group of 10 people, one of those people is going to have a seizure. And in terms of dogs and cats, it's something we talk about a lot, we think about a lot, but in reality, it's a fairly small percentage of the population are going to have epilepsy, meaning a recurrent seizure disorder. So in dogs, that's going to be less than 1%. Same thing with cats, even lower. Now, certain breeds are predisposed, so you can get up to 10% of specific breeds. I'd like to go over some definitions and terminology. I apologize if through this lecture I say words fast that without thinking, so I'm going to try to define them ahead of time so everyone can follow along. But it's a little bit second nature with me sometimes, but I do my best. So first, let's start with seizures. At its root, a seizure is excessive synchronous, usually self-limiting neuronal activity in the brain. What that means is on a day-to-day basis, if I want to perform a task, if I want to lift this coffee mug, it's full of tea now, but if I want to lift this tea mug to my mouth, one part of my brain is going to fire those synapses in the neurons. Very specific portion. It's going to do it in a coordinated manner. It's going to start and stop when I want it to. What happens with a seizure is all of the neurons in that area are firing at different rates. So the second line here, it's a sudden burst. So everything starts firing at once. Nothing's coordinated. And that is what causes the clinical signs. You get this twitching, you get this paddling, you can have foaming at the mouth, loss of consciousness. And the important thing about a seizure is that it's typically self-limiting. We'll get to some areas that, later in the lecture about times when it is not stopping, and that is those are emergency scenarios. So that's a seizure. A seizure does not equal epilepsy. If you have one seizure, you are technically not an epileptic. So epilepsy is a disease of the brain, this is characterized through our consensus statements, characterized by an enduring predisposition to generate epileptic seizures. That just means you're going to have multiple seizures in your life. You have a seizure disorder. So I sometimes use them interchangeably, but just know there is a difference. This word ictus, I will likely say a lot today. Ictus is a word we use in place of seizure. So ictus is the seizure itself. We describe the time period before it as the preictal period. Also, you'll hear it called the prodrome or the aura. This is right before the seizure starts. And then the postictal period is the period after a seizure where you're going to get some behavior changes. Cluster seizures are super important to understand. That is greater than or equal to 3 seizures in a 24-hour period. We'll talk about those many, many more times through this lecture. And similarly to status epilepticus, which is a fun word to say, but it's a very dangerous scenario where a seizure is occurring for greater than or equal to 5 minutes. Other terms I'm going to use are generalized versus partial seizures. A generalized seizure, you may have heard it called a tonic-clonic, a grand mal. We prefer generalized because there's no ambiguity as to what you're talking about. You can have only tonic and only clonic, not necessarily a tonic-clonic seizure. And grand mal seems to be falling out of favor as well. So this is your more classic seizures. Some you see it on TV. Someone falls over, they're unconscious, they're paddling, they're foaming at the mouth. In this, and I like the word generalized because, like we talked about before, all of the neurons in the entire brain are misfiring, and therefore your entire body is not functioning properly, and you lose consciousness. So these can occur on their own, or they can be a progression from a partial seizure, which is the next. A focal or partial seizure is when you have misfiring of neurons in one portion of the brain. So what you may see there is only one side of the body affected. You may see jaw chattering. You may see eye twitching. You may actually retain consciousness there. So those are two important distinctions in terms of seizures. So then when I meet a seizure patient for the first time, there's 3 big categories in terms of what is causing that seizure. And it's my job to try and figure out which one is most likely, because it does change the discussion. It changes prognosis, changes how we proceed. So the first big category are reactive or metabolic seizures, which I'll go into next. The 3 categories are reactive, metabolic, structural, and idiopathic, or genetic is the other word, but really we use idiopathic most commonly in veterinary medicine. So reactive and metabolic seizures. I'm sorry if this slide gets a little worriedy, but these are seizures that occur from a systemic disturbance. So these are things outside of the central nervous system. And when I say central nervous system, I mean brain and spinal cord and your nerves. So these can be toxins. Listed here are some, they're not super common, but these are toxins that can cause seizures. Uh, Things that we will see at our ER. Um, they can be metabolic disorders. What I mean by metabolic, I mean organ dysfunction or electrolyte disorders. Frequently, I see a lot of seizures, obviously, but in the percentage of population, it's low. But frequently, we see pets with something called a portosystemic shunt, which is an abnormal blood vessel in the liver, which prevents the liver from filtering the neurotoxins and basically poisons in the body. And then there's a higher percentage that get to the brain and can cause seizures. Uh, there is a little bit of a misnomer in that, okay, I had a seizure because I had a low blood sugar, my hypoglycemia, pets. And so therefore I don't need anti-seizure medications, and that if I correct that blood sugar, I'm never going to have another seizure. While this can be true, and I certainly hope it is true in cases, it's not always true. Sometimes pets can develop what we call a seizure focus. So their brain, I've had one seizure and now my brain is primed and I can start having more seizures. So while this is the goal and this is ideal, and you treat these reactive and metabolic seizures by treating the underlying cause, it's not always a perfect cure. I think that's essentially what I just said. So you got to try to find the underlying cause, address that first, but you do have to give anti-seizure medications concurrently. Okay, so that's one category. So those are things outside the central nervous system that are causing seizures. The next big category is what we call structural epilepsy. So these are things that are inside the central nervous system that are causing seizures. So with this, we're talking about inflammatory or infectious diseases, traumatic disease processes, developmental or anomalous. You weren't born with the appropriate shape of your brain. Cancerous causes, strokes can cause seizures. They are distinct from seizures. Degenerative diseases, so you can have breakdown of your brain tissue over time. You can have storage diseases. I mentioned Laflora's because it's a common disease I'm asked about, and something that's well described, where you get metabolic buildup in your cells, and so those cells stop functioning like they should. So with structural epilepsy, these are most often accompanied with what I'm going to call neurologic dysfunction, meaning your pet or a pet coming in with this cannot function normally like it should. It has some malawareness of the environment around it, doesn't know where its paws are in space, circles, gets lost, things like that. To definitively diagnose structural epilepsy, you technically need advanced imaging, which would be either an MRI or CT, which we'll get into. There are ways around this because of the necessity for anesthesia. It's not for every pet. Okay, so that's second category. So we got metabolic reactive, we got structural, and now we're on to idiopathic. Idiopathic epilepsy, I have slash genetic slash inherited. Really, what we call this is most often is idiopathic, and I'll go into, when you can qualify for the other two. But this is when we have ruled out metabolic and reactive causes. We've ruled out structural causes, at least to a strong degree. And you have a pet that falls in the specific categories of, you got to be from 6 months to 6 years old, can maybe push it a little bit later to 7. You have to have no interictal neurologic deficits. So there's that word again, ictal. Interictal means between seizures. And I don't mean if you have 3 seizures in one day, you have a seizure, and then that hour between no deficits. I mean, you had a seizure a month ago and you have a seizure now, and there has been no changes in that pet since that time. So that's what I mean by interictal neurologic deficits. So your normal pet between your seizures. And then we talk about advanced brain imaging and spinal fluid analysis as the definitive way. You're looking for a normal brain, you're looking for normal spinal fluid. I will say this is preferred. It is absolutely, absolutely not essential in my practice. Um, for me, being suspicious of idiopathic epilepsy. The alternative is, okay, I have a normal pet on examination today who's having seizures. I'm going to get him back in a few months, and we're going to repeat an exam and make sure it's still normal. If you have structural disease, typically those are progressive. So you're going to eventually have the onset of neurologic deficits or changes to a patient's neurologic examination in between those seizures. So that's another way to get around it. Also, if they're young, they've been normal their whole life and they have a seizure, there's a very, very strong level of confidence that they are idiopathic. So yes, I love to have an MRI and a CT, or a CT, preferably an MRI, in my opinion. But it's expensive, it requires anesthesia. So uh, this slide is talking a little bit about the differences in genetic and inherited. This is something that's more well known in humans, or there's a little bit more study in it. Uh, Idiopathic is what we call it when, okay, you don't have any metabolic reactive causes, you don't have any structural causes, you're normal, you're probably idiopathic. We just don't know why. Generally, what's happening with those pets is it's a problem at the molecular level in the cell, something we call a channelopathy. So that means an abnormal design and production of your ion channels in your nerve, which help your nerves to connect synapse to each other in an appropriate manner. So we have characterized this in a few breeds. Don't ask me what the exact ion channel that is affected is, but we know we've characterized the gene mutation in certain breeds. And so we can call those genetic because we know the genetic mechanism. This is all semantics, really. I just want you guys to have the knowledge because you're going to see different things if you're looking this up online. And so we call it genetic when we know the specific channelopathy or the gene mutation. We call it idiopathic when we have no idea, but we're pretty sure it is a channelopathy. And then the other one, inherited, is I don't know the genetic makeup, but there's a very high percentage of a certain breed that is passing on these genes for seizures. So we like to call it inherited in those cases. Again, I mostly use the term idiopathic. I like to keep it simple. Um, if we have specifics, great. And I think ultimately it's important that in vet med we discover the genetic cause because it might help us to treat these pets. But as of now, it hasn't, at least in my practice, really affected how I treat them and my success rates. This is just another small of the total list of breeds that have some predisposition for seizures. It is, again, not exhaustive. There are many, many more, many, many studies to see which pets are affected. So feline seizures, just a little aside, I think for this entire talk, it's pretty interchangeable, but there's some differences in terms of appearance of seizures. So I just want to say that they do happen. There is a little bit of a misnomer, even in the veterinary community when I was in school, that any cat that has a seizure has a brain tumor. It's instant. Okay, that's it. And that's just not true. We're finding out more and more that idiopathic epilepsy, meaning you don't have any structural disease, you don't have any organ dysfunction, is actually quite common in cats, and that epilepsy does happen in cats. It's difficult, and I'll go into the next slide. Cat seizures can look a lot different from dog generalized seizures. So I think with modern day technologies, getting videos, everybody connecting with each other, we are getting better and better at diagnosing feline seizures. But in the past, people just didn't think they happened, or that they happened very rarely, and because they're only looking for generalized seizures, like typical of a dog. Um, and we don't. There's been a couple studies, but we don't that may say there's some breed dispositions, may not. So it's a big maybe on that one. Uh, so like I said, they can look very different. Uh, Cats, we always say cats do what they want. So they can just have whatever they want for a seizure, which can be difficult. Um, it can be as little as I've had pets who just had a 5 minute period of extreme aggression, and then they would calm back down. There was no loss of consciousness, no falling on your side, no paddling, just purely aggression. Now, your cat may just have periods of that when it plays. It doesn't mean every cat that has episodic aggression has a seizure, but it's something. I don't say this to scare you, but we can have seizures that look only like that. And then it can kind of be the middle of the road where you're just getting drooling and your pupils are dilating and constricting and you have a little bit of facial twitching, but it's not falling on your side. And then you can also have cats who have full generalized seizures who lose consciousness. So we try to keep an eye out for abnormal behaviors in cats that are extreme and start and stop in a short period. And I'm probably going to say this 10 more times during this talk, but if you can, please, 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 please get a video of behavior. I know it's the last thing you want to do when your pet is having abnormal neurologic episodes, but videos of behavior help extremely with trying to diagnose whether something's a seizure or not. Um, okay, so let's get on to diagnosis. And I kind of was just talking about this, but really it's all about seeing the episode. There's some other ways to help, but diagnosing a seizure is entirely based on your witnessing or description of the episode. So with videos, they're just super, super important. And I think we are more and more being able to diagnose or even undiagnosed, so to say, pets with seizures. So pets who have had quote unquote seizures their whole life, we get a video, that's not a seizure. There's lots of other neurologic episodes that pets have that aren't seizures. It's just what we talk about the most. And in the past, pet has a transient neurologic episode. Okay, it's a seizure. We're going to treat you with certain medications. So super, super important to get videos. And I think that's going to be the best diagnostic tool for us, helping you, us as vets helping you. We talked about it a little bit. This is your classic seizure. So things that we're looking for in a description: loss of consciousness, rhythmic paddling of the limbs, foaming of the mouth. We're going to look for changes in the pupils, loss of bowel or bladder, vomiting. These are what we call autonomic components. So it's your autonomic system, your flight or flight system, your rest or digest system that start acting abnormally. So your whole body, including that portion of your autonomic nervous system, are not functioning during a seizure. So you're going to get abnormal behavior in those systems. And then the other thing we're looking for are either pre-ictal or post-ictal, so before or after a seizure changes. Does your pet collapse and fall right back and stand up and act like nothing's happened? It may not be a seizure. Most seizures, even partial seizures, pets are going to act abnormal after the actual seizure event itself. So they're not going to have the same behavior that's occurring during the seizure, but they might be a little bit dazed. They might wander around the house, be a little bit more tired. So those are things that can help us diagnose a pet with seizures. So I want to show a couple videos of seizures. I just want to stress if these can be a little bit tough to look at. So please, 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 if you don't want to look at them, just turn the screen off. It's only going to be about a minute or two, but I do think it's important that we, at least observe a video of what a typical seizure and a partial seizure should look like. Okay, so I'm gonna switch over the slide now, and these are videos from my time at school. So these are actually pretty old, so I apologize for the quality. Um, these are so this is a German Shepherd who moves into a generalized seizure. You can see facial twitching, paw paddling, laterally recumbent. This pet is, yes, the eyes are open, but if you were to call his name, you would not get a response. This pet is unconscious or has an altered consciousness. And then this is more classic of a partial seizure. So what you'll see here is just the jaw chattering, right? This pet could move and walk, it's a little off balance, maybe responsive. You see the eye switching. And then right at the end there, this pet's actually moving into, I'll show it one more time. Right at the end, this pet moves into a generalized seizure. So this is a partial seizure. Not all partial seizures turn into generalized seizures, but that's what they can look like. Just one part of the body acting abnormally. Okay. So, those are mainly we're going to diagnose this with a description with a video. Um, I get asked a lot about electroencephalography, EEG. It always makes me think of Doc from Back to the Future. That's why I put this here. They are, it's a good test. It's a lot better in humans because they don't wiggle as much, if that makes any sense. They're very sensitive electrodes that have to go on a pet's head. So if you look at this diagram at the bottom, this is what's called a montage. And these are all these little dots are where the electrodes have to go. And in pets, because they have fur, we don't have great surface leads or surface contacts where we can just stick them on. So we actually end up having to use these small little needles. So they're not the most comfortable test. And if a pet moves or runs and doesn't sit still, you're going to get abnormal. I lost my picture, but I had one on here. It kind of looks like a lie detector test when it comes out. You're going to get abnormal waves that you're not going to be able to read. You're not going to be able to assess. And there are some veterinarians who, their one big specialty is very into electroencephalography and they make it work. I have a little bit of difficulty. More often than not, I'm using it on pets who are severely sedated or affected in the ICU to see if they're continuing to have seizures because you're not necessarily going to have outward signs. Uh, and the other thing is you oftentimes have to sedate or anesthetize pets to get a test. So it's not always the most practical test. While I would love to do it, um, I generally, more often than not, I'm not doing this test. So then that's how we kind of diagnose the seizure. Okay, you're having seizures. And then what we have to do is try to categorize, well, okay, which category do you fall into? If you remember, metabolic reactive, structural, or idiopathic. So what we're going to do there is first things first, and it's not on here, is a physical exam and a neurologic examination. Those are hugely, hugely important. Like we talked about, your idiopathics are going to have a normal neurologic examination, and your structural epileptics are going to have abnormal, most of the time, neurologic examinations. Then we're going to do some accessory tests. So we're going to look at blood screens, routine hemogram, serum chemistry, urinalysis. I would say we're going to do at least those two. This second category here, accessory blood tests, is not going to happen on every single pet. Um, Bile acids, cortisol, acid-based drug screens, these are all things to look at other portions of the body, other organ systems. And then we might do some imaging of chest and abdomen, heart, if we think, hey, you got a big heart murmur, we want to make sure you're not having a predisposition to having strokes, or hey, you have pneumonia, or we think you have that liver shunt. So these are all things to help rule in or out the metabolic causes, as well as structural, which is the neurologic examination. Then the next thing we talk about, especially in cases that do have neurologic deficits or changes, are whether or not to do an MRI. So it's probably it is one of the most common discussions that I'm having on a day-to-day basis is, we want to do an MRI, we want to make sure. And absolutely, I say every day, if I didn't need anesthesia in pets to perform an MRI, I'd probably do it on 90% of my patients because I want to know what your brain looks like, even though I think it's normal. So it's really a loaded question. This is an expensive test, requires anesthesia, which is not benign by any means. It's safe in 99% of pets, but there's 1% that have issues and can have problems with anesthesia. So I don't force it on anyone. And so I try to weigh the patient, the exam, and the likelihood that I'm going to find something on that MRI. And the next question I ask is, are we going to do anything with that? Okay, I think your pet has a brain tumor. Do you want to proceed with definitive therapy, which would be radiation therapy? A lot of times everyone's different. There's no judgment whatsoever, but you got to kind of ask those questions first before you necessarily jump right into an MRI. So I love having it. I would love to have more MRIs, but certainly it is a case by case basis, and I do not require it for pets. Again, what we can do are what I call serial neurologic examinations, repeating neurologic examinations. So just wanted to give you guys an idea on what an MRI looks like. So this is a very normal, happy brain. So say we do a scan like this, a pet's having seizures. I'm going to be calling this pet an idiopathic as long as the blood work and everything looks good. See nice wrinkles on the brain. These bits of white here are what are called the ventricles. That's where the spinal fluid flows. Everything looks nice and spaced out. I'm showing you this now because I'm going to bring up some abnormals, so you guys have an idea on things that we've seen and have looked for. So this is I think it's a fun MRI to look at, but it is a structural development. This is a young animal, starts having seizures. And if you notice, so normal's on the left. If you look here, nice wrinkles, everything's good. These are muscles on the outside, the muscles over top of the skull, and the trachea is down here. And then what you notice on the picture on the right is where those wrinkles go. There's none, right? So this is what we call smooth brain. That's not the technical term, sorry. This is technically called lissencephaly. This is a little bit of a tongue twister, but this is a migrational developmental issue in pets that are younger. So their brain just never develops with the amount of wrinkles. We call them, they're called sulci and gyri. And so one of the most common issues is seizures. Now, this is unlikely to be progressive with certain pets, but we do have to treat the seizures, and they're had a few. They're very difficult to treat the seizures, so I find these are difficult patients to get control of. And then we have the opposite problem. So this, if you look, there's too many wrinkles here. So this is called polymicrogyria, which is another mouthful. Which again, developmental issue, younger pet, going to potentially have seizures. They'll have some other clinical signs as well. These pets are difficult to train, don't learn bathroom habits well. Those are some other common things. This is that same disease process looking in the lateral, what we call a sagittal section. So the sections before are what I would call a bread loaf or axial. So we're kind of dividing the skull in a bread loaf slices. And if we look here, we're looking from nose to tail. So we're kind of going right down midline. And you have nose at the left and the neck at the right. And so that's a sagittal view of the brain that we're looking at. And you can see there's too many wrinkles right here. So then we have another sagittal view. This is an example of a cancerous process that occurs in a brain. So you have a normal on the left. And if you can see here on the right, so you kind of nose on the left, neck on the right, all the throat and mouth down towards the bottom of the picture. And this is your brain here. So this right here, this little mini brain in the back is called the cerebellum. Notice how squeezed that is? This thing it's lost all of its nice white area around it. It's flattened. what is occurring here is something called herniation or squeezing of the brain out of the skull. There's only so much room in the skull. And the reason that's occurring is this kind of big glaring mass that's in the front of the brain. So this is the type of cancer called a meningioma. It's a surface, so it kind of grows on the front of the brain. And because the skull doesn't move and doesn't have pliability, there's nowhere for that brain to go. So that can cause seizures and certainly other neurologic deficits. This dog was unable to walk at the time. This dog actually did really well. It had surgery to remove that, which is not always actually rarely the case that we feel that is necessary or achievable, and is, as far as I know, doing fairly well. But again, still has seizures, even though you remove that tumor. You still have to treat with anti-seizure medications. And then this would be examples of other structural brain disease, inflammatory. So normal on the left, bread loaf slice. The slice in the middle is an autoimmune inflammatory disease. So you get attack of the brain by the body's immune system. That can cause seizures. And then the one on the right is a little bit of trauma and a little bit of infectious. So this was a dog bite that broke into the skull and then got infected. So then you got an abscess there. So both things that can cause seizures in these pets. So then the other tests we're going to do are, if we end up doing an MRI, we're going to pair that more often with something called a spinal fluid collection or CSF tap. So the goal of this is that MRI is just a picture. We're not analyzing the cells. We're not analyzing the brain. It's not a biopsy of the brain. So what we can do is take a sample of the fluid around the brain and try to get an idea on if there's an increase in inflammatory or infective cells. So that's what the little red arrow indicates. We have to do it when they're under anesthesia. Um, as you can see, there's not a whole lot of room between this little bright pocket right here, where you enter and where the brainstem and spinal cord are. So you have to be very delicate, very slow about it. This is the picture of how we do that. So pets are under anesthesia. Their head's going to be flexed, and we are sticking this small little needle very, very slowly until we get some spinal fluid for analysis. So then let's move on to treatment. Because, okay, great, we diagnosed it, we got our whatever category that the pet falls into, but how do we treat it? So when to start treatment? Sorry, this slide's a little bit wordy. Not all pets need treatment just because they have a seizure. So generally our goals, which I'll go into in a couple of slides, are going to be getting no more than one seizure every 3 months. So if you have a pet who has a seizure and they have two or more in a 6-month period, so you're getting below that goal, then I'm going to be recommending we start treatment. If the pet is older than 7 or has some evidence of structural disease, probably going to be a little bit more aggressive about recommending treatment. The reason for that is I think there's a high likelihood that that pet is going to have another seizure. And so I'm not as lenient. So this rule of 2 or more in a 6-month period really falls for what I would say are the classic idiopathic pets. If you don't fall in that category, if you're in the structural category, or even if you're older and there might be structural disease, I'm probably going to be a little more aggressive about recommending treatment. The other reason is if you have cluster seizures or status epilepticus, so you have more than 3 seizures in a 24-hour period, that meets our criteria above anyway, or you had a very long seizure. Reason for that is those are emergency scenarios, and I don't want to have another emergency scenario. So I want to try to get treatment started as soon as possible. And then if your postictal period was unusually long or severe, I've had pets who they had a seizure and then they were aggressive for 2 days following that seizure and they were a danger to their family. I don't care if that's one-time seizure. I don't really want that to occur again, or I want to do my best for that not to occur again. So those are other reasons for me to get started. Ideally, earlier is better. We know that continued seizure activity can propagate and make long-term treatment a little bit more difficult. So I do keep somewhat of a tight leash on those when I'm not. So here's our treatment goals. I'll say gold standard, and we're always trying to achieve is curing quote unquote seizures, or seizure freedom is the other uh, terminology that people say. I I have I will say that it's very infrequent that I cure a pet from seizures. Usually, what I'm talking about at appointments or with seizure pets is it is highly likely your pet is going to have another seizure. If you look at this stat here, 15 to 24% achieve remission. It's really good, but it's still 1 to 3 years. So they're still going to potentially have another seizure. So while that's great, and I would love if I could cure every pet from seizures, I'd be a very wealthy man if I could. Uh, it's typically not the case. And so, uh, more realistic and more what I strive for and I'm very happy with is if we can have no more than one seizure every 3 months. That equates to 4 seizures a year. Or if you have a really tough pet who's having a lot of seizures very frequently, trying to get 3 times your baseline. So if you have a seizure once a week, if I can get to once every 3 weeks, I'll be very happy with that too. Other goals are decreasing the severity of the seizure, preventing clusters or status epilepticus, so things that cause the pet to need to be hospitalized. Hospitalizations are very expensive. They're life-threatening when you have these issues occur. And then really very important goal is avoiding adverse effects of the medication. So yeah, if I could cure a pet's seizures, but they were a puddle on the ground because they were so sedate from the anti-seizure medications, I don't see that as a high quality of life. And so I'm going to back off those medications and accept that we're going to have some additional seizures. So it's a balance. There's no definitive black and white. It really is depending on every single case. Every pet's different. Every owner's different. Then there's a category of seizures we term refractory epileptics or drug-resistant epileptics. In humans, it's actually about a third of known epileptics. Pets, we've done some studies about 25%. And so these are pets who have been on trials of 2 or more appropriately dosed anti-epileptic medications and have had no response in the frequency or severity of their seizures. That's what we term refractory epileptics. In the past, and this thought process is, I wouldn't say starting to change completely, but starting to have some new insight into it. In the past, if you were deemed refractory, very unlikely that additional seizures or additional seizure medications are going to actually have a positive benefit. There's some evidence recently in humans that that may not necessarily be true, and that it's more a result of you just got to find the right medication. I think the number was about 50, it was about 30 to 50% of refractory epileptics found improved frequency with the trial of additional medication. So your fourth, your fifth, your sixth medication. So, not for everyone. Again, every pet's different, every owner's different, and again, it's a lower percentage of pets that are going to get here, but it's something we have to be aware of. And that's when we start thinking about alternative treatments and medications and trials. So I won't go into every one of these. I had the slides up, but I think we're running a little bit late on time. These are our most common, at least at AMC, these are our most common anti-epileptic medications. Phenobarbital is certainly the most well used traditionally in veterinary medicine. Uh, and potassium bromide is a very old medication. That's from about, it was first introduced to humans about 1857. I'll say this, potassium bromide cannot be used in cats. It can cause a fatal pneumonitis in them. Uh, Keppra, and zonisamide. So these four are our main, what I'm going to call maintenance medications you're going to take every day. Personally, I am first line medication is going to be Keppra for me, and that's mostly because it's tolerated so well. So it's not necessarily the most effective medication, but I think if it works, it's very well tolerated. Pets get a little bit tired on it, but then they resolve, and there's not a whole lot of systemic side effects. Each one of these medications is going to have specific parameters in terms of how many times a day you use it, how often do you have to follow up with your vet for blood work for these medications. So kind of have to have those talks individually about the pros and cons of each. Phenobarbital is the quote unquote most effective medication we have, but even in studies, it got 80 to 82% response from pets. So nothing's perfect. And, kind of going back to our refractory, if one doesn't work, it doesn't necessarily mean another one's going to work. And it may be worth trialing alternative, different medications. At some point with my patients, I get to, okay, you're on your fifth or sixth medication, and with the refractories, again, there's a very small percentage of seizure pets. You get to your fifth or sixth medication, it's not working. We're not seeing a huge benefit. Sometimes I start to back down and take them off for quality of life purposes because it can be very burdensome to have that many medications to give by and keep track of. And then the second set category down below of we call cluster buster medications are emergency medications that help to um, have around if a pet is known to have a prolonged seizure, status epilepticus, or cluster seizures, meaning three or more seizures in a 24-hour. So these are medications that can be given orally, um, intranasally, or rectally as well. So things that owners can have at home to help prevent needing to come into the emergency room. So which one do we pick first? I kind of touched on this a little bit. It oftentimes goes with your vet's opinion, what they feel comfortable with, your pet, how often they're having seizures, how severe those seizures are, do they need to be hospitalized? So there's not one perfect answer. And everyone's going to have different opinions. Every neurologist is going to have opinions. All the neurologists at AMC have somewhat differing opinions too, even though we were all trained together. So it's a complex question, and you got to find the right one for you and your pet. I would say that again, tolerability is the most important thing to me, because I think the I want to maximize the chances we're going to get that medication into the pet, and that's going to be given consistently, which is very important. A little note on liquid compounding. Some pets do not like tablets, and that's okay. And I think some medications better than none, but specifically, and compounding is getting better and better. So this may be outdated information, but I have had some pets who had liquid compounded medications, and they always had a seizure towards the end of the month when that medication was starting to run out, and that's because it was separating out. I think again, I haven't seen a lot of that recently, and I think it could be as simple as shaking up the medication each time you give it, but something to be aware of. So if you're not getting benefit with a liquid compounded medication, try to use the manufacturer or the generic form of tablet. Um, but again, some pets, hey, especially cats, some medications better than nothing. Touching on the cluster buster medications again. So these are medications to help you and your pet stay out of the ER, in case it's a pet who is known to have multiple seizures in one day. Then there's alternative therapies. This is not exhaustive, but these are some of the most common that I talk about. In general, other than this category of vagal stimulators, I term these as no harm therapies. The biggest thing that I recommend is that you don't use these in place of traditional therapies. You still have to be on your anti-seizure medications, but these may help. These may help improve frequency and severity as well. The studies are very mixed on these. Diet, one of the most common I'm talking about, specifically, it's an increase in medium chain triglycerides in the diet, or quote unquote ketogenic diet. I generally recommend the big name brands who have had a lot of study behind them and a lot of research behind them, and they can, in some larger studies, they've benefited about 50% of pets. So that's really good. I have anecdotally had a couple of clients work with a certified nutritionist to form a balanced ketogenic diet and actually have very good improvement in control. So that's something to consider. Acupuncture can help. There's some interesting studies where they actually implant these little gold beads under acupuncture points to keep them stimulated. And that had about 50% of pets responded to that. CBD, there's a lot of newer and emerging research, but similarly, if it works, fantastic, uh, and generally is no harm. I just recommend with CBD getting a brand that is certified or tested at least. Don't get it from your, kind of random shop around the corner, just in case. Um, so that it's, safe and controlled, and we can keep eye on dosages. I think that's the newer thing is trying to figure out what dose is going to be effective. And then there's this new cool therapy that's more emerging called a vagal stimulator. I don't perform this procedure or implant it as of yet. We're going to look into it if some more research comes out. But there's a nice, what it is putting in a pacemaker-like device uh, attached to your vagus nerve, to the pet's vagus nerve in the neck. And by repeatedly stimulating the vagus nerve, you can actually help to improve seizure frequency and control. Now, a lot of the studies on this are done in refractory epileptics, so these are harder to manage epileptics. But there's one that came out in 2023 with 12 pets, which is vet med in a nutshell. We never have um, enough study enough participants or study subjects, but 12 pets, and about half of them had improved of refractory. So these are difficult to manage epileptics. About half of them had improvement in their frequency. So that's maybe on the horizon as something that's going to change how we treat here. So quickly, I just wanted to go over emergency scenarios and when you should see a vet. Um, if it is your pet's first seizure ever, you should absolutely try to seek emergency examination or call your vet, see if they're open. A lot of vets will take same day appointments if they have time. Because I think it's important to get an examination then, get some blood work, make sure you don't have any of those reactive or metabolic issues going on, and get checked out. If your pet then becomes a known epileptic, hey, I'm an idiopathic epileptic, I'm going to have a seizure once every 3 months. It's fairly typical. It's 2 minutes in length. Then it stops and he recovers well. You don't need to go to the vet every single time, and you don't need to tell your vet every single time. Um, Now you can, of course, but my recommendation more so is keep a journal. Keep a journal and keep dates. Keep dates on when those seizures are occurring. So then you can visualize and track, okay, they're having their seizure once every 3 months. That's expected. Fine. Oh, the last seizure was only a month ago. This is starting to increase in frequency. And so then that spurs, okay, I should make an appointment with my vet. These are starting to increase in frequency, or at least call my vet. Maybe I need to make some adjustments to my anti-epileptic plan. Other reasons to seek emergency uh, care are cluster seizures. So you got three or more. Even if you're a known epileptic and you've been given your cluster buster plan, you got those medications. If you got three or more seizures in a 24-hour period, you got to go into the ER. The reason for that is they're going to be able to have IV access to give typically a benzodiazepine medication to help stop that seizure chain. And then generally, we're going to recommend hospitalization overnight for monitoring, because if those seizures continue, we may have to have constant drip rates of medications, things to prevent severe, we call morbidities or associated damage that can occur from prolonged seizures or multiple seizures. Same thing goes for status epilepticus. You got a seizure that's occurring, it's 5 minutes or longer. We'll go in, but basically, if you're able to witness a seizure or you know your pet is prone to having long seizures and you're seeing a seizure, start timing it. And if you feel like it's going to get a little bit longer, get your coat on and start getting out the door. If it stops before the 5 minutes, great, turn around and go back home. Oh, you're fine. But it's always good to be ready with that. And then other reasons that come in, you're starting to see your pet's abnormal between seizures, not associated with a seizure. You don't necessarily have to go in emergently, but you might want to call your vet, see if they can fit you in. So it's sooner rather than later. Don't wait too long on those. But if they're severely affected and you're worried about their mental state or they can't walk or anything like that, absolutely come in. Or they're not recovering from their last seizure as they once did. So those are all reasons for me to come more in emergently. So what should seizures are tough. You kind of feel helpless during a seizure, and there is not that much to do, really. If you have emergency medications on hand, you can try to give them. I can tell you that giving an intranasal medication during an active generalized seizure is a challenge and a challenge in coordination. Trying to get this little tube into a nose while a pet is moving around is very difficult. Um, but that's certainly one thing to do if you have those emergency medications. So we have intranasal or or rectal medications we can apply during or right following a seizure. And we have oral medication called clorazepate, which you can give once the pet is up enough to take an oral medication. And we can give that a few times a day for a couple of days to help prevent more seizures from occurring in that short time span. The most important thing to do if you're around for a seizure is prevent your pet and yourself from getting hurt. So you can see a lot of pets who have generalized seizures are going to do a lot of that jaw um, chomping. And so that can be potentially dangerous. So don't put your hand near their mouth. You do not have to pull the tongue. They can't swallow their tongue. If they're on a high surface, try to get them onto the ground, onto their side, so that they're not falling off a high surface. Okay. Other things, take a video. I know that sounds like the last thing you want to do, but it's really important, especially if you haven't taken a video before for your vet. Hey, what does this look like? Is this a seizure? How long did it act? I think it's something you can do at least. And then once they're done with a seizure, comfort them, and be with them. But there's not, I don't recommend splashing water on them. I don't recommend pressing on their eyeballs. Those are maneuvers you hear about that might have a benefit, but I just the majority of seizures are self-limiting, and the last thing you want is for your pet to hurt itself or for you to get hurt by your pet during a seizure, because that complicates the whole situation. Okay. And then this, I think, is my last slide. So prognosis. So it really depends. There's been a few studies, but more of them state that the lifespan of an idiopathic epileptic is not necessarily decreased as compared to a normal dog, which is really great news. So these dogs who are idiopathic epileptics can live normal, happy, healthy lives. Now that is complicated if they become a refractory epileptic or they become a pet who has cluster seizures or status epilepticus and they need to be hospitalized frequently. So it's not every idiopathic, but they certainly can have a very normal lifespan. Unfortunately, pets who are diagnosed with structural epilepsy, typically the more progressive or malignant types, brain tumors, infectious, inflammatory, actually have a reduced lifespan. So it really depends on what's causing the seizure, how severe the seizures are. Interesting a survey of owners and when pets were put to sleep for this or passed from this, they actually found that the most important factor for quality of life and lifespan of a pet so lifespan of the pet is the quality of life and the perceived difficulties in caring for the pet. So again, no judgment to any owner. Epilepsy can be very difficult to manage. It is typically a lifelong condition. You have to give medications every day. You have to be aware of it. So, but I think that speaks towards the positive in that a lot of these pets don't care. Okay, I have a seizure, and then I'm a happy boy the rest. You're a happy boy, happy girl the rest of the day. it's I think pets can do just fine with it. They can just do fine with it. So it oftentimes is us as owners as we're stressed out, and that's reasonable. I'm not saying that's wrong, um, but knowing that I have very infrequently seen a pet that I thought was perceiving that their quality of life was lower because of the seizures that were occurring. It's more often than not because we're loading them up on too many medications, and they're sedate and they can't do the things they like to do. So, yeah. So I hope that I know that was a lot. I'm sorry I rushed through that and we're a little bit jammed on time, but I'd like to just open up for some questions and hopefully that was informative for you guys.
Thank you so much. That was very thorough. I know it was a very big topic to take on, but
Mm.
you did a great
Mhm.
job. So we have some questions. We'll get to a few. We had several people asking in just basically, can pets be weaned off medications?
Yeah, absolutely. Um, my rule of thumb, I'm a little bit neurotic, no pun intended, but I generally want a pet to be seizure free for at least a year. Sometimes I'll use 6 months if it was a one-time seizure and I never thought they were going to have another seizure. But if it's an epileptic that's had a few, or it was a pet that bumped its head and had a seizure. I'm generally trying to get that pet seizure free for at least a year. If it's really burdensome, the medications, then I'll go as early as 6 months, and then take them off. Now, depending on the medication, you have to taper some medications. Part of the reason I like Keppra is because you can just stop it. So that depends a little bit too. But yes, absolutely.
Okay, great. We had a few questions about what is going on in the brain during the post-ictal period.
Yeah, it's a good question. The way I think about it is that those neurons aren't necessarily having that same level of burst activity. They're not all firing at the same time, but they're recovering. They're not, they then need to perform their normal functions and they're just a little bit slower. And so that can be one thought process with it. The other is you can actually get some inflammation. It's called neuroexcitotoxicity. You can get some inflammation in the brain tissue itself that just takes a few days to resolve. And so that can affect your brain processes, either temporary for a few hours, or you can get what are called post-ictal deficits. So my blink response doesn't work like it should, and that can be up to a day to 3 days following. You can have temporary blindness in pets following. So those are all reasons why we're going to get abnormal neurologic um, behavior following a seizure, but that should resolve. That should resolve in a reasonable time span.
Okay. We also had a question about if your dog is having seizures, should you still get vaccinations?
Good question. I would say I do recommend them in idiopathics that we know, and we have a high suspicion of idiopathics. There are certain structural diseases where I actually recommend against vaccinations. And again, this is always my caveat. I don't have any legal power to say you are not getting, because rabies is a
Right.
legal issue, rabies vaccination, but there is some very small connection with relapses and autoimmune diseases that can occur from seizures. Very, very weak evidence in veterinary medicine, but that autoimmune inflammatory disease can be life-threatening. So that's one instance where I say don't get a vaccination. Um, in terms of connection with vaccination and just idiopathic epileptics, I don't think there's a whole lot out there to prove that they're connected. So I generally recommend that pets still get vaccinated.
Okay. Great. Question, is there any connection between FIV and seizures in cats?
A very roundabout connection is a very good question and something that still plagues me a little bit. So hopefully I answer this satisfactorily. It's not a word. There can be changes with FIV and chronic FIV. You can get some changes to the vasculature in the brain. And I don't know if any of you have ever seen the bodies exhibit and seen the blood vessels that make up the brain, but essentially it looks like a normal brain just on blood vessels. So if you start affecting those blood vessels and affecting the oxygen flow and energy metabolism of the brain, you can start to get abnormal firing of those neurons. And yes, you can have seizures. I would say I maybe once or twice have been convinced of an FIV cat that had seizures, but it is reported.
Okay. Okay, great. Um,
Sorry.
what specifically should we do? You kind of touched on this, but in the moments, but I guess specifically the moments following a seizure. Usually my dog's head is covered in sweat. Sometimes he's
Mm,
bleeding from the mouth a
mm,
little.
mm,
He's usually out of breath, wanting to run
mm.
around the house. I've
Yeah,
been told a lot what to do during a seizure, but not
yeah.
what to do in order to help him recover during the moments after and the
Yes,
rest of the day.
is a very good question. I think in general, I think comforting your pet or allowing them if he wants to run around, doing it in a controlled manner. I don't think, and every pet's different, but I don't think forcing a pet to stay in one area really helps because they're gonna kind of want to get, they're anxious. They're gonna want to get out and run if that's the behavior that they're doing afterwards. Checking them for any major wounds, a little, I bit my tongue, probably doesn't need to go to the vet, but making sure there's nothing more major that's occurred. But yeah, that post-ictal period can be difficult, and there's not a whole lot to reverse it quicker. So it's kind of just allowing them to do the behaviors that they want to do, but in a controlled manner, that is safe for them, and making sure that there hasn't been any major damage caused.
Okay, great. We had a question that their dog tends to have seizures between 11 p.m. and 1 a.m. Is
Yeah.
that normal that it could be the same time as
Yes,
the
yes, and I'm sorry I didn't touch on that. That's actually the most common. About 75% of pets with seizures are going to have them at rest. So it's actually less common for pets to have seizures when they're active. And part of our description and part of us thinking about what's a seizure and what isn't a seizure is if a pet has it when they're active, it's kind of lowers it on my list of that's a seizure. So having them overnight at rest is the most common. And the way I rationalize that to myself is during the day you're distracted and your brain is actually functioning to do multiple tasks and maybe is inhibiting a seizure from occurring. But as soon as you rest and everything kind of dampens down, it allows it to have that abnormal burst of activity.
Okay, great. We have many people saying thank you so much for this. It was really informative and wonderful, and many clients and saying how much the neurology services helped them. So thank you all for saying
Thank
that
you.
too. Um, let's see, what is recommended for a metabolic seizure from hypoglycemia?
Yeah, good. Um, Loaded question. I could do an entire lecture on that.
Okay.
But first off is going to be correcting the hypoglycemia. And typically, there's very specific numbers of glucose that we see. So you could have a relative hypoglycemia of 60 or 70. It's unlikely to cause a seizure. Once you're getting below 50, 55, so most commonly when I'm seeing it is neonates, so young pets who don't have the fat stores and they're not eating, so their body cannot produce the blood glucose. Other reasonably common hypoglycemic seizure episodes we're seeing is pets who have pancreatic disorders uh, that are overproducing insulin, and then their blood glucose drops, or diabetics who get an overdose of insulin. So, uh, first things first, you got to correct the glucose. So you got to have an IV injection of usually dextrose. That can be done through any emergency room. Uh, Rubbing Caro syrup on the gums in a puppy might help. Sometimes can be helpful, but really correcting it intravenously is going to be the most important step.
Great. Let's see, we had a question. Can seizures cause organ damage?
Hmm. Yes. So again, loaded question, but something we talk about, um, especially with status epilepticus or cluster seizures. Uh, we can have a lot of what are called comorbidities that occur. And in dogs, the shock organ, meaning you're in some type of neurogenic shock, is actually the gastrointestinal tract. So you can have damage to the lining of the gastrointestinal tract. If you seize enough, you can actually go into something called multi-organ dysfunction syndrome, ODS. So you can start getting shut down of your organs. These are all really end stage, very severe seizures when they occur. I've had pets who had a seizure and then they had onset of lung disease,
Mhm.
something called non-cardiogenic pulmonary edema. So absolutely it can. Uh, it is not, it is the, I wouldn't say exception, but it's more rare for to occur. And it usually happens with more severe seizures or prolonged or multiple seizures in one day, which is why we take such active measures in preventing clusters or status epilepticus.
Great. Is my dog in pain during a seizure or after?
Yeah, very common question. Um, and without sounding callous, at least during a seizure, and it's tough because I have looked into this myself and try to ask some friends who are epileptic and look up reports. Generally not during, at least what I think, because they're unconscious, with generalized seizures. So they're not perceiving anything. You're kind of, it's almost as if you're not there. Right. So I don't think they're in pain during. It just looks, it's really scary to look at. Very hard to look at. Afterwards, generally not, maybe a little bit of a headache type feeling, or if they did hurt themselves on the ground or something like that, but not an extreme pain or anything like that. It's more of a dulled sensation, lack of being able to interact, almost like when you wake up really groggy, from a midday nap or something.
Okay. Okay, great. Let's see. We had a few questions about sound and sound phobias trigger a seizure.
Yeah. Like audiogenic, it's a
Yeah.
term we call audiogenic seizures. Yeah.
Yeah. Okay.
Yeah, it's an interesting subset of patients, but absolutely, yes, sound and lights
Mm.
and even smells in some pets can cause seizures. It's a much lower percentage. I think it's about 20 to, well, overall about 20 to 25% of epileptics are going to have a quote unquote trigger. So triggers are actually less common. That trigger can be lights, sounds, smells, a toy, excitement, something like that. But absolutely. And there's some in cats, there's something called FARS or feline audiogenic reflex seizures. And it's nice that we've classified it because we actually know that Keppra seems to work a little bit better for those pets. So if we can get that part of the history in that part, it can tailor our treatment a little bit.
Okay, great. Let's see. We have many some questions about personality changes. I guess uh, both
Yeah.
medications or can the
Yeah.
seizures themselves cause it or
Yeah, that's a good question. Seizures, you can definitely see personality changes following. Rarely I've seen permanent personality changes following a very severe seizure episode, but again, that's pretty rare. I don't see that often. More often, if you're seeing a personality change, I'm going to be more worried that a pet has a structural problem. So something growing, I had a stroke, something that is damaging a large chunk of the brain tissue that may be involved in the personality.
um, a question about hydrocephalus and seizures, a
Yeah,
connection.
yeah, for sure. Hydrocephalus pets can have seizures. That again, a whole lecture about it because hydrocephalus doesn't always, there are various forms of hydrocephalus, some that need addressing surgically, some that need medications, and some that don't at all. Generally is a congenital malformation where you have too much fluid in the brain, and you get a loss of the brain tissue, the cortex of the brain, with that. So it absolutely can be connected. Um, there's some other hints and clues during an examination or during a history taking that make us think a pet has that. You'll see pets with very domed heads or something called a fontanelle. So it's a little soft spot in the middle of their skull. um, where the bones never fuse together because there's some extra pressure there.
Okay. Great. Okay, this one. Can you give a dog a sweet treat to help recover from the seizure, like a little vanilla ice cream?
I think that's a nice idea. I like
Yeah,
that.
that's
Um,
good.
yeah, I think it's a good idea. Like if your pet will take treats and gets distracted and that helps them through their post-ictal, I think that's fantastic. Um, generally, no, I won't talk about that. There's
Mhm.
some thought that really prolonged seizures can lower the um, something called neuroglycopenia, so you can lower the amount of glucose that's been absorbed by the brain. But if a pet has normal processing of glucose, they don't. My point is they don't necessarily need extra sugars after, but I think it's a great idea to give them a treat that they like after. Helps them get through that rough period following.
Take when you have a treat yourself
Yeah,
too,
exactly.
probably,
It's a
right?
stressful day. I want a
Yes,
treat.
yeah.
I want ice cream
Okay.
personally.
Me too. Um, okay, well, I think we're going to wrap up because we've already gone over, and this was very, very informative. Thank you again, Dr. Cimino.
Yeah,
This
thank
was
you, everyone.
fantastic. And everyone, thank you all so much for joining us. As I mentioned, we'll have this on YouTube tomorrow, and we'll send a link to everyone who registered. Thank you, Kimberly Young, for helping to organize this and all of our events. And everyone, we so appreciate you joining us for these webinars and just spending part of your evening with us. Thank you again, Dr. Cimino, and good night, everyone. Take care.
Thank you. Good night.